Good morning, everyone, and welcome. Thank you for taking the time to attend our discussion on transforming patient pathways. This morning, we're going to be considering the drivers for the extensive change we're already seeing in health and social care pathways, what constitutes that change currently, the direction of travel, as well as hearing from trailblazing thought leaders as to what the coming months and years hold. We'd like to examine with all of you attending the session today, so what are the ramifications and opportunities that this presents to both the health provider and the life science industries. My name is David Wyndham Lewis. I'm a Health and Life Science Director at Atos based in the UK. I spent my entire career working in healthcare, most recently as Chief Information Officer and Director of Transformation at several of the National Health Service acute and mental health trusts in the UK. We really do have some fantastic panelists to talk to you. If I can start with our chair for the discussion panel, Rob Warford. Rob is Head of Global Strategy and Industry Alliance for Health and Life Sciences at Atos, working with our clients, partners, industry and government. So thank you, Rob, for leading the panel discussion for us today. David Roberts is a global leader in health and social care and life sciences, having practiced in over 30 countries. David is the Global Health Sector Lead for EY, with his previous experience including Services Director General for the Australian Department of Health and Human Services, as well as leading several prominent UK National Health Service providers as their Chief Executive. Rachel Dunscombe is Director of Technology and Global Arch Collaborative Lead at Class Research. She's the CEO of the NHS Digital Academy and formerly the CIO and Director of Digital for the Salford Royal NHS and the Northern Care Alliance Group, one of the most digitally mature organisations in the NHS. She's a visiting professor at Imperial College London, advisor to the UK Health Minister and a member of the UK Government's AI Council. And finally, please may I introduce Dr. Tom Mckinnon. Tom is the founder and CEO of Big Picture Medical, a cloud-based platform for distributed healthcare. Tom started his career in finance, undertook a postgraduate degree in medicine, and subsequently trained and worked in emergency medicine. Big Picture Medical was founded in 2014 as a disruptive platform vendor driving distributed models of healthcare with an aim to eradicate systemic inefficiency and enable sustainable, high-quality care. So my thanks to all the panelists for taking the time to share their insights with us today. Some brief housekeeping before we start, if I may. As the panel discussion progresses, we'll be taking questions on the Q&A tab. I do encourage everyone to engage on there. I'll try to answer any questions that I can as we go. And then for our last 10 minutes, we will open up the panel members to the questions you've posted. If you'd like to direct a question to a particular panel member, then please can you note that at the start of your posted question. So with that, may I please pass over to Rob Warford, who will introduce our topic and begin the panel discussion.
Thank you, David. I hope you're all sitting comfortably, for most of us probably in our homes. If so, welcome to your new hospital. COVID has made a massive impact on the way we live and the way that care is delivered, with the majority of primary and elective care now being carried out virtually. However, the writing was, to some extent, on the wall prior to COVID, with Forrester predicting the number of episodes of care carried out virtually were to exceed 36 million globally in 2020. So the question must be asked, is COVID creating a new direction of travel, or is it merely acting as a catalyst to a pre-existing trajectory that would inevitably, in time, play out? Put simply, we need to understand why care pathways were changing prior to COVID, and to what extent the new parameters brought on by COVID change or enforce our prior concepts and ways of thinking about our future. How does the change we are witnessing affect the quality of care? Is it even possible to carry out care effectively over a video call or to treat a patient remotely for the majority of clinics today? To what extent will the adoption of new models caused by COVID retreat back to former ways post-COVID? Simply, is the change sustainable? So let's first look at some of the reasons why there was increasing adoption of virtual care prior to COVID. It's a reasonably well understood fact that the population is aging, we're living longer, and there's growing demand on the healthcare system, which outstrips available resource. So, David, To help us understand this better, would you mind sharing some thoughts on the megatrends at play globally, both those which are causing the need for change as well as those which are creating opportunity for change?
Trends that you've just put up have been with us for some while. And I think we're seeing a major shift take place at speed at the moment. And we'll talk some more about that. But there are 5 things that have been happening over the last few years, and they are changing in momentum. The first of them is that I think we're all used to the fact that the place of care, or where care is actually received, is moving from more of an institutional basis, hospital basis, physical fabric basis into people's homes. And when we describe homes, we mean anywhere, actually. Logical solution.
I think we're just losing David there. So whilst we probably...
So would you like me to pick up on that? I think it's...
Thank you, Rachel.
Yes, so I think this is a trend which has been expedited in terms of COVID. Much of the technology was existing, but I think the point that I would bring up is the nuances about how we've adopted it. We've adopted it monolithically at pace, and I think that's something that we really need to explore in terms of how we adopt and adapt pathways rather than just digitize the analog.
Thanks, Rachel. So this raises the question. So we can see from the statistics that long-term conditions, for example, are reputed to be responsible for 7 out of 10 pounds, dollars or cents spent on healthcare. This sounds expensive. With the aging demographic and increasing incidence of chronic conditions, at what point will we see demand exceeding capacity in a detrimental way? Or have we already reached that point? What can we expect to see over the coming years? If David is able to join us, David, feel free to answer. If not, I'll open that, Rachel, to yourself.
So I think from my perspective, what we're seeing here is a need to align the resources of the system with the demands of the system. We've really worked in terms of care and pathways by rote. And what we need to do is to diffuse our offers so that we can actually align the resources that we have with individuals that need that. And that is very much about understanding individualized need. And it's very much backed by data. And so we need to move away from one size fits all and care by rote to personalized and precision pathways. And that in itself will allow us to have more impact with the money we spend today. But indeed, I think many parts of healthcare systems in the world are seeing long-term conditions actually causing major and escalating impacts on their outcomes and indeed their GDP. And until we align our resources for our system to have the maximum beneficial effect and impact on wellness for our populations, we are not going to have the right return on our digital health investment or indeed our healthcare system investment.
Thanks, Rachel. So we talked about aligning systems and systemic change. What does the concept of a healthcare ecosystem need to look like to deliver the care we need?
So we started the session initially talking about the home being the place of care. And so our healthcare ecosystem, as I see it, really is the emerging infrastructure that allows us to deliver care in any geography or location that is suitable. And so really we're moving away from the currency of a healthcare system being skills and buildings to being skills and a flexible workforce and technology. And that ecosystem is made up of many offers which unconstrain the geography of care.
I think we're just losing Rachel. I think we just lost you at the end there, Rachel. So I think what we're seeing here is the need for optimizing technology. It's a problem we should be focusing on. So I think if we've achieved something with this, it's certainly with that. So moving on to the next slide. So we've talked about the care system and the problems facing it, but what about the patient? Even before we recognize the concept of healthcare consumerism and patient-centered care, healthcare is always and should always be about the patient. So let's consider a scenario that the statistics evidence to be a common experience for many patients today. Anne lives with a long-term degenerative condition. Keeping appointments with her specialist doctors and getting to hospital for checkups is her part-time job, which is affecting her ability to attend her real job, as well as costing travel expense and stress to attend appointments, which are often not needed or which are not effective as her clinical information is not shared efficiently between the multiple clinicians managing her different conditions. This might seem like an exaggerated view, but it's actually too close to the truth, and in some cases the truth is far worse. So there are lots of broken links in this example. Rachel, in your experience, what's standing in the way of effective, efficient care? Are today's clinical software systems helping with this? How are they going to fix this?
Systemic design. We have designed both physical systems of care, but also technical systems that are fragmented, and they don't focus around the individual. When we come to technical systems, we've created huge numbers of data silos, and our technical teams, CIOs, are at cognitive load or over cognitive load in terms of trying to manage the very disparate sets of data that they have. What we need to do is create a citizen-centric set of data, which will allow a longitudinal record and will allow clean, codified, real-time data to be available for automation, risk stratification, personalized care, personalized medicine. That in turn is going to take a different set of design principles. Design principles where we design the data of our citizens being for their lifetime, to be used for their care and wellness for their lifetime, and to be available to all caregivers and all caregiving organizations and systems. That's something that we traditionally have not done. We've bought very tactically, we've stored our data very tactically, but that clean, codified, real-time data is something our citizens can and will demand, and is something that will absolutely be essential for us to have that citizen-centric set of care pathways, which will allow us to treat people in a personalised way and make most use of the system resources in doing so.
Thanks, Rachel. So some really interesting insights there. Often it's at the detail where these things are made or broken. So we've talked about some fairly high-level concepts there, but coming down a layer, could you help us understand how the actual architecture is contributing towards solving or actually creating a problem here?
So traditionally, many software vendors have really locked data in as part of their strategy, I guess, to retain customers. I think that is true to say. But actually, as we move into a world now where our citizens are co-creating data with us, and we need to transact data across many different organizations, the only logical way to move is to data standardization, to open data standards. And that means that the myriad of new data sources that we will be producing from Internet of Things and wearables and the citizens' collected outcomes will be able to be merged in and used as part of the clinical record. And so I think we've got to a point now where those data silos have to break down, and we need to design for open data. Indeed, in a world where we have open standards, which are actually designed by clinicians and patients to serve the needs of these use cases, then we should be converging towards that. But we are in a place where many industries are actually still using their own bespoke data formats, and that takes time to change. But for clinical safety as well, I would make an argument that we do need to use clean data in open formats. so that we understand that an apple in one place means an apple in another place. In the world of AI, we have to do this as well, because the more we have to transform data, the more friction.
Okay, thank you, Rachel. So we've understood that this is a complex, interconnected challenge that relies on the underlying architecture to actually fix. We can't necessarily move forward in a sustainable and effective way without addressing that underlying infrastructure and platform. So it's an interconnected challenge where the issues in the system are therefore related to the solution. So just like the body, it's all connected, and a holistic approach is needed. In an integrated care system, the key components of patient-centric services cannot operate in isolation. So the electronic healthcare, telehealth, offers tremendous potential to transform services, but on their own, they will achieve a measured success, but won't be appropriate for a large body of patients. They need to be joined together in a connected ecosystem. Fundamentally, we need to address the issues within the enabling digital architecture to enable data liquidity. So working towards an ecosystem approach, we have sought to align different solution components that address each phase of a patient pathway to enable end-to-end holistic and sustainable pathway transformation. So on the screen we're sharing different stages of the journey. So one company that understands the importance of connected ecosystems is Big Picture. So Tom, we've categorized you here in the triage box, but we can't really put the big picture in a box, right? So a couple of questions, Tom. We've heard how the underlying technology can ironically create a barrier to change. This is something that has been
followed by the pound or hash sign.
Tell us about the need you saw and what Big Picture is doing about this.
Yeah, sure. Thanks, Rob. I think it comes down to, we all know, the patient journeys, it's really changed organically over many years. It's evolved from the one patient to one doctor in one location. And now it's evolved into, one patient, many care providers, many locations, including as David was saying, at home as well. So in order to, service this, the underlying software infrastructure was originally built around this one-to-one relationship, and it's no longer suited to, the new distributed patient journey. And so in order to provide the safe, convenient, cost-effective care, healthcare effectively needs a new technology stack that does cover that entire patient journey, including the patient at home. This has actually occurred, in other sectors, but it hasn't occurred in healthcare yet. So what we did at Big Picture is over the last years, we've taken design thinking and we've really developed the new global technology stack for healthcare. That's not saying that, it's looking to replace the existing technologies or new technologies that want to come on board. But what it's doing is it's rather providing them with an integrated pathway to work together, so the innovation can work together to allow for that distributed care to be delivered. And so we believe really the right software stack to drive the ecosystem, that Rachel was talking about is absolutely critical.
So if I've understood you right, Tom, you're saying that we need a software capability that enables is configurable to enable these new models of care to be constructed with workflow, if I've got you.
Yeah, absolutely. So it's not the one patient, one doctor journey. That patient will have an entirely different pathway, and the underlying software needs to be configurable to be able to deal with that. And that's essentially what we've been doing. So we don't solve every problem, but we create that infrastructure that allows others who have got innovative ideas to be able to link into, to be able to provide that patient journey, provide the patient with a distributed patient care journey.
Thanks, Tom. So could you try and bring this to life for us? So if we looked at an example of a patient journey that you've changed and where you might be doing that today.
Yeah, sure. I think practical example would be a good one to do is we've had a deployment in operation at Moorfields Eye Hospital in the United Kingdom. They're one of the world's preeminent eye hospitals, and they had a problem. And in fact, many hospitals have got these problems, and it's not just in eye care, it's in any area of medicine. That in essence, they were getting many patients being referred to come and see the specialist face-to-face, when in reality, a lot of them, those referrals, could actually be done differently. So using our platform, what we did is we enabled the community optometrists in the high street to work collaboratively with the specialist eye doctors at Moorfields to deliver a distributed patient journey. So in that way, what Moorfields were able to do is they were able to prevent over 50% of those patients that were going to have to go to the hospital for the face-to-face appointment and, wait 4 months for that appointment with a specialist. And once they get there, typically it takes, can take up to 4 hours. What they're able to do is actually completely change that and keep them out of the hospital system. So obviously it's much more convenient there for the patient. But it's also great for the clinicians and the specialists because they've got all the information that they need in order to diagnose the patient remotely. And they can see the patients 5 times faster using our platform than they can, in a face-to-face clinic. So it takes a specialist roughly 2.9 minutes to review the patient remotely and provide that opinion, diagnosis and management. Not only that, from a healthcare perspective, the economic benefits, we've got to consider them as well, and they're equally as impressive. It doesn't just avoid the face-to-face specialist consult, or the 50% of them that we were talking about, but what it does do is it leads, importantly, to a much more effective risk stratification. So those patients that were kept out, those patients that were told that they needed to come to hospital, they're actually risk stratified better. So those that do need to come are actually getting to see the specialist earlier, and they're getting diagnosed earlier, and they're getting treated earlier. And obviously that has significant economic implications.
Great. Thank you, Tom. So, Rachel, I'd like to bring you into this. I know that from your days at Salford Royal, pathway transformation was something of a labour of love for you. Would you mind sharing a little bit about how you went around developing and bringing together an ecosystem of partners, as we're suggesting here, to enable effective transformation?
Absolutely. And I think in what you said about telehealth, it's absolutely true. Telehealth by itself does not transform care. It just replaces, the traditional appointment. What we did at Salford Royal was we really looked at pathways like the renal pathway, both those people with renal failure and those on the transplant pathway, and looked at what they needed in the home. And we actually segmented that pathway into people that could take a fully digital intervention, and our average age was early 60s actually for the pathway, and up to, I think it was around about 83 to 85% of people took that pathway up. There were then people that wanted or needed the more traditional pathway. We had around about 10% of people taking that up. And then with the time that we had freed up from those that were self-caring and self-managing at home, we were actually able to make a super sort of intense pathway for those people who were likely to exacerbate or admit, who got more face-to-face time. And that's how we aligned our sort of resources within the system. But what we did was we worked with user-centered designers. We worked with consumer-facing technologies, actually, in terms of working out what would be an applicable sort of profile or persona for people who would take up the digital pathway. And the pathway itself was not just about telehealth appointments. It was about home urine testing. It was about Bluetooth scales. It was about other devices and self-reported outcomes using, mobile apps. And that in turn then allowed, just as, we've talked about with Dr. Tom, the clinicians to actually make a decision with that data coming in real time about how often a patient would be seen, or whether a patient needed to be seen by exception using telehealth or face-to-face. We found that pathway was very, effective for us, and our renal teams embraced it. But the wonderful side effect of that was we had more of our patients remaining in jobs and education who had renal failure. And that was a huge life impact, because that in turn improved the economic outlook and also the sort of mental health profile of that patient group. So when you start looking at these redesign pieces, it's really about one size does not fit all. It's not just about moving from outpatients appointments in the home to outpatients appointments via telehealth. It's about everything you need in the ecosystem around it for that pathway. but they can really improve lives and save lives. And we were certainly getting much better outcomes from the home-based pathway than we were prior to that.
Thank you, Rachel, for that insight. It's fantastic to hear how that changed pathway was improving patients' health and also their financial stability, and lives at home and wellness. So we do believe that our capabilities at Atos in digital strategy and transformation program design and change management, system configuration and helper interaction centers can create this holistic approach to change. We've illustrated here how we can bring together a different ecosystem of partners to create a holistic approach. And to expand on that as we draw our discussion to a close, how can we help transform and accelerate change at scale, which is evidently so much required? We've seen a massive shift to virtual models of care. The talk today has only highlighted the challenges of using technology to enable new pathways, and it's absolutely right that we consider how we optimize those new services and models. So firstly, we can offer world-class multi-channel appointment booking and administration. Circa 25% of a hospital's costs are spent on administration, with various benchmarking reports evidencing that a significant proportion of this is being spent on tasks such as booking and administration of appointments, writing clinical outcome letters and related activities. We can offer an improved patient interface with online portals and contact center services that allow efficient management of appointments and high quality patient experience. We can optimize those processes either with technology or business process outsourcing. Secondly, as Tom shared with us, we can assist in the design and digital enablement of new care pathways, which enable care to be delivered closer to or from a patient's home. And thirdly, we can define and optimize the most effective medium of clinic delivery, as Rachel mentioned, to make sure that we're providing the appropriate medium of care supported with proper medical device integration, diagnostics equipment integration to make it an effective clinic. And lastly, once the clinic's finished, our work has just begun. With the deployment of appropriate remote monitoring devices and integration to the patient medical record, we can ensure that appropriate follow-up care is needed as required to ensure cost efficiency, reduce deterioration of the patient's condition, and to avoid admission or readmission to the urgent care pathway. So we started out with this discussion asking the question of, is COVID a catalyst? Is it accelerating a set of pre-existing parameters, simply accelerating the current trajectory, or is it fundamentally changing the parameters of direction? David, I hope you're back with us to help bring this discussion to a conclusion.
Robert, yes, I am. And how sad and disappointing is it that technology lets us down in this way? And of course, sometimes this does happen when we provide virtual solutions as well. Look, COVID is an accelerator. There's no question in my mind. But this journey was commenced before that, as you quite rightly set out at the beginning. I think the difference for us now is that we've proven to ourselves, we've proven to our physicians, we've proven to patients that actually this can work really well. And so all the things that we thought impact us and help us have just been enabled in a very different way. Consumers are being enabled by technologies that are advancing at a very rapid pace. Advanced technologies, AI, the integration of these into ecosystems is all actually accelerating what we do. And I think we're all becoming very comfortable that we've got a sensible way of executing care. And prior to COVID, I think we were genuinely nervous about it. Clinicians weren't too sure, and patients were unclear about how it would work. But apart from the inevitable glitches like we've had today from being in a remote location, actually pretty much it works. What we do find, though, is the proof of making this work is that we understand the underlying data. Because if we don't get to grips with how our systems interact, how our data flows around an ecosystem, we're actually not going to be able to make this a safe process for people. We also need to remember that industries and working is here to stay.
I think we'll give David just a second to see if the connection resumes. So David Wyndham Lewis, I think we'll move to David. You back with us? I'm sorry, you're struggling. David Wyndham Lewis, would you like to lead us through any questions that we might have come through the portal for any of the panelists?
Yes, absolutely, Rob. And obviously recognising the time, I know we're going to lose a number of our attendees. So what I would firstly say is thank you. There have been an awful lot of questions asked by the Q&A tool. Those that we can't address now, we will answer on the tool. I would also note that the session's been recorded and will be available to everyone further down the line as well. So we will make sure we pick up with all the questions asked as we progress through the rest of today. So the first question that's come through that perhaps needs a bit more discussion was around how this can be used to drive preventative efforts in regard to care rather than reactive care. I was wondering, Rachel, could I pass that to you to start us off?
Absolutely, and I think as we get more and more data, we find early signals in terms of ill health. Some of the work that I did a number of years ago actually was around using health coaches based on some of the data that we obtained from an integrated record in Manchester. And the whole idea that we will learn more about early signals and interventions. Indeed, I was talking yesterday to some of the folks at, Public Health England around interventions for coaching and health outcomes and how we would decide whether they're targeted. And the interesting thing for me here is we can learn an awful lot from retail about how you do target interventions. So, how do you actually sell fitness, wellness, sell prevention programs? And I think, the audience segmentation and what we've learned about how different groups act, where public health, population health, and the data we get from individuals and populations sit together, will really help us drive that agenda. And it will also help individuals to understand what is applicable for a person like them. Because before now, we've done things on a one-size-fits-all basis. But those that really do want to keep well and stay well will be able to actually, participate in their own wellness programs. So I'm very optimistic that the future will, bring this. But as David said earlier, it is absolutely all about having the right data in the right format, that is clean, open, codified data that can be used for these journeys for our citizens.
Fantastic, thank you, Rachel. I'm acutely aware we have run over time, and I'm getting some reminders of the fact. So with that, and with apologies to everyone who's asked other questions, I'm afraid I will have to draw us to a close. May I thank our presenters and our panelists, so David Roberts, Rachel Dunscombe, Tom Mckinnon, and Rob Warford. As I said a moment ago, we will make sure we've answered all your questions on the Q&A panel, and I will more than happily route any of those on to David, Rachel, or Tom further down the line. So my thanks to the panelists, and my thanks to all of you for attending.